And we're back. It's peptides and age management with our favorite doctor, Dr. Kris. Dr. Kris Wusterhausen of the Research Clinic. And just so you guys know, these conversations are intended as educational, and always consult your physician before changing your medical program. So, Dr. Kris, how you doing?
Good, Steve. How are you doing today?
I'm excellent. We've had some rain. I'm in Texas, and so we've been having our rainy season. I think it's lasted 2 days or so,
Okay. Okay, good.
but it's nice. The temperature was like 77 degrees earlier, so not a bad deal. How about on your end?
About the same. Had a little bit of rain, not too hot. I'm sure by the weekend and the 4th, it'll be back up close to 100. So we'll just enjoy the cooler weather while it lasts.
All right. So today is we're talking about something that probably most couples don't know about, and it's called the PulseWave treatment. And for many folks, when they have erectile dysfunction in their lives, the typical mindset is to take some medication to try to address this. But there are other options, and one of them is PulseWave. Tell us a little bit about it.
So PulseWave is a non-invasive procedure that's FDA approved for increasing blood flow. And the device has actually been around for quite a few years. It was originally used for plantar fasciitis and tennis elbow, and technically it's called low intensity shockwave therapy. So I always tell patients, some people use the term pulse wave, some use the term shock wave, some even use the term of acoustic wave. At the end of the day, if a provider is talking about one of those three entities, they're actually talking about the same thing. So it can get confusing for the consumer sometimes because they hear these different terms. But basically what we're using is a handheld device that creates a wave that will penetrate through the penis and around the penis. And what it's ultimately doing is it's increasing blood flow. Well, how's it doing that? It's doing it by two ways. It's trying to break up the microcalcifications, the minor blockages in these vessels that are there, is trying to disintegrate those so that we reintroduce blood flow that way. But it's also creating what we call neovascularization, which is actually the creation of new blood vessels to the penis. So I always tell patients, because I grew up in West Texas, we're trying to get fluid from point A to point B, in this case, blood flow. And we're trying to do it via cleaning out the old pipes and laying down new pipes. And so that's how we do it. And the other thing that's great about PulseWave is the FDA has classified it as a class 1 device, which means that the device is deemed harmless. So as I always tell my patients, they're like, what's the worst thing that can happen? Well, it not working is the worst thing that could happen. I can't hurt you with it. I can't make your erectile dysfunction worse with it. And so that's the real good part about this, because so many things that we do in medicine have a lot of adverse events along with possible benefits.
So, Dr. Kris, who's a good candidate? Obviously, we can guess, but let's hear it from you.
So what I tell my patients is first of all, I think I like to just talk about the stats, because so many men are, even in my practice, and this is what we do, and they know this is what we do, and they know that, hey, they do hormones and exercise and nutrition and ED. They're still hesitant to bring this up with me, even though I'm a guy, I'm their age many times, or at least around their age. So I try to always use the stats that 40% of 40-year-olds, 50% of 50-year-olds, 60% of 60-year-olds, you get the point, of men actually have some form of organic erectile dysfunction. So it's very, very common. And so I just think it's really, really important that the patient understands how common this is. As far as who is this for, the other thing I try to really tell my patients is that the sooner that we treat your erectile dysfunction, the better chance of success and the better results that you're going to experience. When I have guys that walk into my office and I start asking about their erections, and I say, can you get an erection? No. Do you get morning erections? No. Well, can you have an erection good enough for penetration under any circumstance? No. Well, unfortunately, I know right then and there I've got a severe ED patient, and my success rate with that patient gets much closer to 50-50. Whereas if I have a guy who simply tells me, my erections aren't what they used to be, but I can get them for the most part all the time, that's more of a mild ED patient. And we're able to treat that guy with like a 75 to 80% success rate, or maybe even above. So the biggest thing that I do is I try to tell all my new male patients, hey, do you have any issues? And if they say no, I'm like, that's great. I'm happy that you don't. If you ever start having problems, let's really address it quickly. Let's not let it go. Let's not be embarrassed to bring it up. I always tell them, sex is a 3-letter word around here that we don't find bad. We're cool with talking about it. Don't hesitate. And then if a patient really does want to do the procedure, we actually do what's called a SHIM questionnaire, which is a sexual health questionnaire. And it's just a few questions. It's quick and easy, but then that can really help me discern who's a good candidate and who's not.
So can you tell by a body style on a guy who might be struggling with ED?
Well, we're going to know that somebody who has metabolic disease is going to be at a higher risk for erectile dysfunction. So, such as like we call it metabolic syndrome patients, and those are going to be your overweight patients. So that guy that has the belly and that visceral fat, and because of the inflammatory diseases associated with that, we know that patient's going to have a higher incidence of erectile dysfunction. What's quite crazy though is at times is that sometimes those patients come in and they're very fit and they can actually have organic erectile dysfunction. But that's also where it's my job to sit down and really discern with that patient. Do they have real erectile dysfunction, or are they maybe having a psychologic block that's causing their erectile dysfunction? And, that is much more common than we think. I get a lot of young guys that come in for erectile dysfunction consults, and most of the time they don't have real erectile dysfunction, organic or erectile dysfunction. They just have some sort of a psychologic barrier that we have to help them through with other things.
So when we think about the PulseWave treatment and we're growing new blood vessels, or you're breaking up the plaque and then you're generating new blood vessel growth, how does that work? That seems kind of I never considered that we could be growing new blood vessels.
Yeah, it's what's kind of cool is that actual shock waves or pulse waves that are going through there actually cause the body, because of the micro trauma that is occurring, actually causes new blood vessels to form. And that's why also some guys go, okay, what's the post care for PulseWave? And guys always get a kick out of this one. I always say I want them to try and get an erection twice a day, because we want the blood vessels to form, but also go in the right direction. Blood vessels aren't going to go towards the tip of the penis unless there's consistent blood flow pushing those vessels in that direction. So many times they say, my wife's never going to believe this. And so sometimes I'll even write it down for them, like, here, I want this guy to have an erection twice a day. That's also why in our moderate to severe patients, we'll actually recommend a penis pump. Success rates are a little bit better with the pumps. And, if you tell a guy with severe ED to get an erection twice a day, he's like, if I could get an erection twice a day, I wouldn't be here. Mm-hmm. And so we'll use that pump to basically pull that blood to the tip of the penis and have them leave it on for a few minutes, again, trying to get those vessels to form.
So how do these conversations start? I mean, it's obviously a sensitive topic. Most guys would hate to admit that they're starting to notice that things don't work like it used to. Maybe is this a conversation the wife starts?
Not usually. Usually, it can be. Most of my guys will come in by themselves when it's up to this topic. I think it's, in my practice, I think many times it's me that starts the conversation by just bringing the topic up. We have a questionnaire that our patients do every time in, and certainly on their erections, they can put if they're having any problems there. So sometimes they'll simply mark that question, which will prompt me to start the conversation. Sometimes it's after guys have seen me a few times. Maybe they see me 2 or 3 times and they get a comfort level that, this guy's okay. And a lot of times I just bring it up. I'll just start talking to them about sex life. Like, hey, how's your sex life? Is everything good performance wise? I try to make it as casual as possible. I try to make them feel like it's not something bad that we can't talk about without getting embarrassed. And that generally works for me. Now, with that being said, I'm still sure there's quite a few of my guys that maybe still don't bring it up, but because at some point it is up to the patient to bring it up if they're having the problem. But it's not nearly as taboo as I think it was 5, 6, 7 years ago, with especially with and you know what? That's another way they'll bring it up. Hey doc, can you tell me a little bit about Cialis or Viagra? Which is sometimes their way of tiptoeing into the subject as well for the patient.
So let's say we made it through that uncomfortable conversation. We're starting to feel better. And what's this treatment like? How to do it? Is there preparation? Do I have to change anything? Do I have to fast for a week before? What goes on?
Which, by the way, you'll have to check with me later. Crescent and I are trying to do our first 40-hour fast, so I'm about halfway in right now. But luckily with PulseWave, or maybe unluckily, there's no prep of any kind. So what we try to tell our patients is so I try to put them in categories of moderate, mild, moderate, severe, or somewhere in between those. So sometimes I'll say, I really believe you're a mild, moderate, moderate to severe, or severe. And really what I tell my patients I'm trying to do there is I'm trying to give them a realistic expectation of how many treatments they're going to need. And generally, we only sell or only do the PulseWave in packages of 6. Studies have shown that if a guy has erectile dysfunction, less than 6 treatments together simply just isn't going to work. So those men typically come in 1 to 2 times a week, depending on their schedule, for the procedure. The procedure takes only about 20 to 25 minutes. There can be some discomfort with the PulseWave treatment. Some guys simply are more sensitive there than others. And if they are sensitive, we actually then just apply a topical numbing solution, which then makes the procedure 100% painless. And I stand behind that. But some of my guys don't like the numbing gel because everything there goes numb for about 4 hours, and it's quite a weird sensation for a guy, I believe. So some of my guys do it without the numbing gel the first time. We're like, oh, well, that doesn't hurt, and so we'll do it without numbing gel. So I'd say it's about 60 to 70% use no numbing gel, and 30 to 40% do. So if you're a mild patient, generally, I usually say it's about 6 treatments. Moderate plus, I usually say 6 to 12. And if it's severe, I say 12 plus treatments. And again, that mild patient's going to have about an 80+% success rate. That moderate's going to be somewhere in about that 65 to 70% success rate. And those severes start to get around 50-50. But of course, there's other things that we can do along with the PulseWave treatment in order to increase the success rate.
So you say once or twice a week. Obviously, there needs to be some time in between treatments.
Right.
Why is that?
Well, because simply we don't believe, and the study hasn't shown that if you if a guy says, I want to come in Monday and Tuesday, well, no, we want to try to do like a Monday, Thursday, or a Monday, Friday, at least a couple days in between the procedure. And actually the stats show that a guy who gets 2 treatments a week versus 1 treatment a week has about a 1 to 2% higher success rate. So it's not major, but some guys say I want the 1 to 2% increased success rate, but it's just found that if you do the procedure too often, you're not piggybacking on their results. There has to be some time for the body to respond. A guy could literally do this procedure every single day and not hurt himself, but I don't believe he's increasing his success rate by doing that.
And so we need that time in between treatments for the new blood vessels to grow?
Yeah, so basically for the micro trauma to and by the way, when I use the term micro trauma, that sounds bad when it comes to the penis, right? And so let's go back and discuss that. I always forget that I don't break that down very well. The patient himself will feel no discomfort or pain after this procedure and throughout the throughout the whole procedure protocol. So I think that's important to notice. The worst thing that can happen to a guy is maybe some bruising, although that is really, really rare. We typically see no side effects whatsoever. I tell my guys, you can go have sex in 10 minutes. You can walk out of my office and go home and have sex. I don't care. That's great. And so there's no pain or discomfort with that. But yes, going back to the actual question, we need to give the body time to heal, to see the results. It's just simply one of those things that we can't hurt you by doing it too much, but we're just not going to see any improvement in the success rate by doing it 3, 4, 5, 6 times a day, a week. That's just not going to improve it. So 1 to 2 times a week. The other thing I won't do is, like, if I have a new patient and maybe they say, well, I want to do 2 treatments, but then I'm going on a 2-week vacation. I'll say simply, like, no, let's just wait till you come back from your vacation, because you can lose some of the success if you do just like, and I've had this happen before where somebody will just do a treatment or 2 or 3, and then they leave and they cancel their appointments and they show back up a month later. And I'm like, well, just so you know, we're pretty much starting back over again, which can be a real negative. But I really try to educate the patients on that, to really have me 3 to 6 weeks per batch that we can knock this out and get it done.
So would there be suggestions of maybe changing your diet, maybe some, I'm just curious what else you would recommend, because most of your practice is more holistic.
Yeah, so we're going to, the one thing I'm always going to ask any male that comes in for PulseWave is, let me look at your hormones. And I also like to look at their blood sugar. I want to make sure they're not diabetic. If they are diabetic, is your diabetes well controlled? Like I had a new patient maybe a couple of weeks ago that came in with really bad erectile dysfunction, but also with an extremely high A1C, which is the 90-day blood sugar test. His diabetes on a scale of 1 to 10 was a 10 on uncontrolled status. And I said, man, I'm not sure if I can even help you, but unless your blood sugars are controlled, there's no help that's going to be seen here. We're not going to succeed. This procedure is not crazy expensive, but it's also not crazy cheap. So you need to go concentrate on your diabetes for 6 months. And then if you can get it under control, we'll sit down and talk again. And then also, if you just have that patient that maybe they're not so, and then also looking at the testosterone levels, of course. So a lot of my ED consults turn into testosterone replacement patients. And then they find that once they replace their testosterone, that their issues aren't nearly as bad and they don't actually have to do the ED treatments. So it can go both ways. But assuming that I've got a male in front of me whose metabolic panel looks good, their hormones are good, they're not diabetic, and then I'll start, looking at their diet, making sure that they're trying to do a low inflammatory diet, a low sugar diet, not a ton of carbs, and then exercise. I mean, there's no doubt that exercise helps as well, just getting the blood flowing, getting the natural testosterone levels up. So, it goes along with everything that we talk about, Steve. The healthier life that we can live, we're definitely not hurting this, and most likely we're helping as well.
So obviously there would be the obvious benefits from the treatment, but talk to us about some psychological or confidence benefits.
And I might even extend that out to just relationship benefits. I'm a firm believer that sex is part of a relationship, a healthy, successful marriage or relationship. I believe that intimacy is crucial to that, no matter what age we are. But also a guy's mental psyche is, I always tell my ladies who ask about this, I say, hey, a guy's psyche is tied around his erections. And if he doesn't have good erections, he's not in the mental place that I guarantee you he really wants to be. But with that being said, the mental aspects can affect our erections as well. So it's a circular pattern there. So it's just really important for the overall mental health and wellness, to make sure that we're addressing this part of our health as well, that we're not letting it, if we're not being too embarrassed to bring it up and letting a situation go for years that could have been easily addressed for a lot less money and a lot less time a few years prior. So that's my biggest, point that I want to make to the patients is bring it up as soon as you can, but maybe also bringing it up to a provider that knows different things to do for ED. Because like I always tell my patients, that's great if Cialis, Levitra, Viagra works for you. I'm not knocking it. It has a lot of, it also can help the prostate and other things. So I'm fine with that. But realize that when you're literally having to use these products for erections, the situation will get worse. It's not just going to stop in time and you're going to be able to take a Viagra and it's going to work forever unless your lifespan is short, because as you age, that blood flow problem is going to get worse. And I tell my patients this all the time, you're going to wake up at some point in your life and go, crap, he's raised my Viagra dose a few times and it's not working. And now you're going to come into my office and you're going to be that severe ED patient that I have a much less chance of being able to help, versus if you'd have just came to me early on, we could have actually fixed this problem. And another thing patients always ask me is, how long will this work for? And I always say, well, unfortunately, we can't stop aging, but the healthier lifestyle that you live, the chance that this lasting longer, patients do typically go on some form of a maintenance program. And there's no standardized maintenance program. I let my patients choose, but I typically have them do at least a treatment every month to every about 6 months, just one treatment, not 6. And most of the time, the guys pick their own frequency, and they'll come in whatever they feel comfortable with. A lot of mine come in monthly, and I'm like, hey, you come in monthly. Do you want to try to, maybe go every other month? They're like, nope, this works for me. My erections are great. I don't even want to risk it. So, because they get comfortable with the procedure after a few, it's not a big deal to them any longer.
So if you're experiencing erectile dysfunction and this treatment is attacking the plaque that's building up in the blood vessels,
right?
It would make sense to me, but I'm asking you, would that be a symptom of other problems you may have throughout the rest of your body?
Absolutely. So obviously the vasculature to our penis is a little bit smaller than the vascular like to our heart in those areas. And many cardiologists will tell you the first sign of actual cardiovascular disease is erectile dysfunction. And I think it's really important that any provider that listens to this or any patient that listens to this, that if you see a guy who's having erectile dysfunction, but has not seen a cardiologist, that you at least make sure that, hey, you need to go see a cardiologist as well. I can treat your erectile dysfunction, but you need to go get your heart checked out, your carotid arteries checked out. Those things that can actually kill us, heart attack, strokes, those sorts of things. And when I got into this, my local cardiologist, I first called him and just to get his opinion on it. He's like, man, I think it's great. But he told me exactly kind of where that question came from. He's like, all I would say is just make sure that these guys, especially if they're younger, have had their heart checked, because you'd be amazed at how many of these patients actually have coronary artery disease and they just don't know it. And you could do a lot of good for them, not only for their ED, but for their long-term overall health.
So tell us a little bit about the hormone treatment. We haven't really spent a lot of time discussing this on the show, and I'd like to explore it more, but there's a lot of benefits there getting your hormones correct.
Yeah. So, that's, like I was telling you, we went out to LA this Saturday and filmed some hormonal videos for a society that's going to be putting out a mastermind on hormone replacement very soon. And, testosterone replacement in men, even though it's quite common these days, even though you can't listen to the radio, a terrestrial radio at least, for more than 2 commercial breaks and not hear a testosterone replacement ad, believe it or not, is still men are still very undertreated across the world, but in the United States on testosterone replacement. And some people really think that the only reason guys take testosterone is just to give us more libido and to have more energy. And it's so much more than that. But even if it stopped at that, that would still be good enough. Luckily, it's not. Like my mentor that I learned under originally, who is a retired urologist, once told me that he was a younger urologist in an older urology group. And he said that one day, one of the older urologists came in and said, I don't know why you do all that testosterone replacement with these guys. All you're doing is making the patients feel better. And my buddy said, well, hell, isn't that a good thing if I'm not hurting them and they feel better? So the good news is with testosterone is that guys feel better on testosterone replacement. But in addition to that, we can build muscle mass, which is, as we age, so crucial. We can build bone density, which is so crucial as we age. We can protect the brain better from dementia. We can have no negative effect on the heart or the prostate in men. Prostate cancer actually goes up in low testosterone and goes down with proper testosterone replacement. So, I always try to tell my patients, I can help your brain, I can help your bones, I can help your muscles. I can hopefully give you a little better libido. And if blood flow is still decent to the penis, we can give you better sexual performance. And we can do it in a safe manner, which is, awesome and very, very important as well. We can also indirectly help, diabetes or prevention of diabetes, because no doubt that when our hormones are imbalanced, we're at a much higher risk for all these different cardiometabolic diseases. So, if a guy just rolled in my office who's 55 years old and says, I want PulseWave, but he hasn't checked his testosterone, or if he's not on testosterone replacement, I believe we have to start with that, the building block, before we go to the PulseWave therapy.
So this supplement, this testosterone supplement, my impression back in the day is once you get on it, then it's going to affect you. It's kind of like the steroid or the iron pumping steroid conversation. Once you get on this, it's going to mess you up later. But that's not the case now.
Yeah, it's can or can't be is what I would say to that question. And so with testosterone replacement, proper testosterone replacement, it depends what the goal is. If a guy's 50, 55, 60, I'll tell him, well, sure, we can take you off of testosterone replacement at some point. If we get to the point where we want to be, if our muscle mass is where we want to be, if our bone density is good, if all these different criteria are met. But you also have to realize that with time, when we stop the testosterone replacement, your testosterone is going to go back down, and you'll probably end up back in my office in the next couple of years with the reoccurrence of these symptoms. Now, in the younger patients, sometimes if you can get a younger patient who maybe they're eating a horrible diet and they're not exercising and they're inflamed and their body's making no testosterone, and maybe if you can get them just feeling better for 6 months, 9 months, 12 months, 15 months, and they can get back in the gym, they can start eating better, they change their whole lifestyle, those patients have a real potential to come off the testosterone at some point. They can have their body start producing the testosterone again to a level that they feel comfortable with. One of the docs I lectured with presented a great case of like a 24, 25-year-old male that was like 400 pounds, and they were able over a year to get like 100 and plus pounds off of him. And then they were able to take him off the testosterone because he could exercise, he ate better, his natural testosterone levels went up, so he didn't need that replacement any longer. So patients fit into different categories, but generally one of the questions I get is, how long can I be on testosterone replacement? And there is no set time that you cannot, like, you don't time out like, oops, it's been 10 years, Steve, time to come off your testosterone. Also, though, there's no set level to replace testosterone anymore. It's all about symptoms. Some of the patients in my practice are former professional athletes. And I might be a little more inclined to treat them at a little bit higher levels of testosterone, because it's my belief if they were a professional athlete, they probably had some really good testosterone levels at some point in their life. So we used to only use like, oh, you're over this level, you can't have testosterone replacement. And doctors who are really mainstream in this now don't believe that's the way we do it. It's really, what are the symptoms? Do we believe the symptoms are going to respond to testosterone replacement? Do we believe replacing it's safe for that patient? Those are the things that we look at.
So is it injections? Is it pellets?
Well, so, I'm always going to lean to the bioidentical aspect of this, and I'm always going to lean towards pellets, but I would be not telling the truth if I said my practice did not use both. So when it comes to testosterone. There's oral testosterone, which in my opinion is not very effective. And I also can maybe debate the safety of that. And if you are going to use it effectively, it has to be done multiple times a day, which most people don't like to do. And then, of course, there's transdermal. Guys aren't real good, in my opinion, at least not in my practice, of actually applying gels and creams once or twice a day. I always make the point, how many times have you put lotion on your body head to toe? And most guys are like, not very often or ever. But you can do transdermal testosterone replacement, which is just through the skin. There can be issues depending on the patient of how well they absorb it, because different people absorb it differently. And then the most common routes are injectable testosterone, which I would say is probably 25% of our practice. It is a synthetic testosterone. And if you look at the testosterone molecule of injectable versus bioidentical, you will see that they're similar, but they're definitely not the same. And I do believe that's why sometimes you might see a little bit increase in side effects of injections versus pellets. And then, of course, there's subcutaneous testosterone replacement, which is AKA pellets. And the reason I like pellets is they're bioidentical, so they're 100% exactly like what's in your body. Two, convenience of administration. In other words, if I can get a guy to come in every 4.5, 5 months, I can do a 10 to 12 minute procedure and they're done with their testosterone replacement till they come back. It's also called pulsatile release. So the example I use with my patients is, if you go into the gym and you're on injections and you start working out, your shot isn't going to go up while you work out. Whatever your level is what your level is. If you go in with pellets, their absorption is based on cardiac output. And what that means is the harder your heart beats, the more blood flow you get around the pellets and the higher your transient level of testosterone goes. So if a guy goes in the gym, gets his heart rate up, blood flow around his pellets goes up, he gets a nice little increase of testosterone while he's working out. That leads to better workouts, less chance of injury, and better recovery. So the negatives of pellets can be the fact that it is a procedure. There can be some soreness and tenderness. There can be some limitations of exercise for 3 to 5 days. A pellet that goes in can come out, although that rate is under 2%. And then the negatives of injections are, you got to be willing to either take a shot or give a shot. And there can be some ups and downs. And then, of course, it's also ups and downs of how you feel. And then, of course, also the fact that they're synthetic, and some patients care about that, others don't.
So there are the benefits. I always hear the low T conversation, or I remember those commercials where you're grumpy, you're tired, you're not sleeping well. What are some of the expected benefits from this?
And so generally what people come in that have low testosterone, they'll have lack of morning erections. They'll just not feel very well. They'll be gaining weight or inability to lose weight. They'll say their mental focus just isn't what it used to be. They'll say, God, I'm ready to go to bed at 6:37, grumpiness with the kids and wife, and poor sleep. And we can continue going on and on and on. And then all the things that issues those can lead to. And I simply tell my patients, the first thing that's going to happen with testosterone replacement, proper testosterone replacement, is you're going to start to feel better. It's going to happen pretty quick, usually about 2 weeks in. Hey, you know what? I'm starting to feel a little better. And I try to tell my patients, it's not like a light switch. It's not like you just go to bed tired one day, wake up the next day feeling 100% rejuvenated. You just start to notice each day gets a little bit better, a little more energy to put your foot on the floor and actually start your day. And then with time, you'll typically start to see libido starting to improve, sexual performance starting to improve. You'll start to notice that not only are your workouts at the gym starting to give you better results, but your enthusiasm for going to the gym starts to improve. In other words, that motivation to actually work out starts to get better. Generally you start to sleep a little bit better. Typically your spouse or your significant other will start to say, oh, you're not nearly as grumpy as you used to be. I always tell my patients, and I believe this to be true, if I went home tonight and told my wife I'm no longer going to take testosterone, I think I'd be having a deep discussion directed at me about why I should stay on it, because my wife claims I'm a much nicer, better person when I'm on testosterone versus when I'm not.
Well, we sure experienced the nice, smart doctor that's helping us learn about stuff. So you stay on that. So it seems like this conversation around erectile dysfunction, obviously, pulse wave treatment is something that people are would want to do. But then it's opening up this conversation about testosterone. What are some other things that this conversation leads to, like peptides or
It just leads to basically all different forms of wellness. I mean, but what I would like to say is what are some of the other things that we can do for erectile dysfunction? And, because not everybody that comes in our office either is willing to do pulse wave, or maybe it's out of their price range, or maybe that's not kind of where they're at yet mentally. So we love to use the peptide PT141 that we've talked about a little bit in the past. And PT141 can be an amazing peptide. It is an injectable peptide, but not into the penis, into the belly. And we've talked about melanotan before, the tanning peptide. So what they found with melanotan is that they found that in men and women, melanotan increases libido, but in men also can increase erections. So the good researchers, the scientists, went out and found out kind of what side chain actually did that, and they cleaved it off, and they came up with PT141. So PT141 is a more intense response with libido and erections, but it does not tan you. So some of my patients will actually use melanotan because they're like, what, if I can get a little bit of both, that's kind of where I want to go. But my patients who really want to just concentrate where it needs to be, that can be many times one of the things that we can add in. We also usually talk to them about oxytocin. I love oxytocin. It's the love hormone. It's the hormone that, secretes. If I was reading the other day, or maybe a provider was presented that this weekend, that if you give someone a 20-second hug, you have a tremendous surge in your oxytocin. Oxytocin not only attracts us to our mates and helps with libido, but it also makes us calmer and nicer. And so it's an amazing hormone, and we typically use it nasally, so it's really easy to use, just a nasal spray. But then we can also talk to them about PRP injections, which is plasma-rich platelets, which is simply we draw their blood, we spin it in a special centrifuge, and we take out the good stuff from the blood and leave behind all the bad stuff, the plasma-poor platelets. And we can get a stem cell-like effect by injecting that back into the shaft of the penis. And I know it sounds horrible. It's really not that bad. But that's another thing many times we'll either do in conjunction with PulseWave or in replacement of PulseWave. We'll typically use it in replacement of PulseWave with a guy maybe having sensitivity issues. So if a guy's like, I get good erections, but orgasming has become quite difficult, then we'll use the PRP typically there. And then last but not least, in our office, we do exosomal PRP injections. So we'll take the PRP, same exact thing that we just talked about, but we'll mix it with exosomes, which come from the umbilical cord of newborns and is kind of the CPU mother cell to stem cells. And we can add that in with the PRP and actually get some really good results as well with stem cells. With ED.
Wow. So this conversation starts to bleed over. Is like when Viagra was popular, people were going, well, what about women?
Mm-hmm.
Why isn't there something for women? Women experience
Mm-hmm.
Arousal challenges. Talk to us a little bit about that, please.
Yeah, so I would actually say I might have just as many, if not more, conversations about this with women than I do men. And I don't mean ED, I just mean sexual dysfunction. I find my ladies are more comfortable bringing this topic up than males are many times. I'm not sure why that is. I would think it'd be the opposite, but it's not. And so, if a lady, one of the common things that ladies start to experience is just lack of sensation as they age. And we can address that multiple ways. Of course, hormone replacement is crucial for that, but also vaginal rejuvenation can be very effective with that. We use the radio frequency device Thermiva in our office, and that's just a heat-based treatment that's typically 3 treatments over once a month for 3 months that can return health to the collagen in the vaginal walls. Many times on that third treatment, we'll do the PRP shot into the G spot in the clitoris, which is basically the equivalent of what we do with men in the penis, except that we're obviously women don't have a penis. So we're injecting that into the O shot into the clitoris to improve sensitivity. If sensitivity is not the issue, if it's just lack of libido despite proper hormone replacement, that's where we kind of get into what we just talked about with either the PT-141 or the oxytocin nasal spray, or possibly combining both of those. I really like the oxytocin nasal spray because it's really inexpensive, doesn't have any real side effects, and it's just easy to try with my patients.
Wow. So none of these conversations, or let's say all of these conversations, at one point, we like to drop the word ketone esters.
Always, right?
So obviously there would be some application here for the ketone esters.
Ketone esters help everything, and so we're such big fans. If we can just help with overall health and how we feel, I think so many couples, one of the things they struggle with is just I hate to say finding time for sex or intimacy, but many times that's exactly what it is. You're on busy schedules, everybody's tired. That's where those ketone esters come in, with just helping clear our brains, helping our cellular function. If our cellular function is good, we feel better. It all just goes in a circular pattern, and so ketone esters help a little bit of everything, in my opinion.
Well, this has been an excellent, Dr. Kris. We've talked about a bunch of things. I've never been on a podcast. We got a comment here. Let's see here. Love those pellets, Deborah Thomas.
Deb's a great patient. She's been with us a long time. She's a great nurse as well.
So, whoever dreamed that we'd be on a podcast where we said penis, where we said clitoris, where we said all these words that we avoid saying all the time. But it's
Howard Stern would be proud, back in the day with the FCC.
So if someone's been listening, they're kind of convinced, I've noticed that some things aren't working like it is. Hormones sounds like a great conversation, but really you need to come in and get some labs done. How can they start that conversation with you, Dr. Kris?
Man, the easiest way is just call our phone number at 817-599-9902. One of my customer representatives will take it from there. I generally like to get patients in for labs, sit down and visit with you. We've now added Maggie, of course, our nurse practitioner as well. So we're able to handle more patients because that was becoming a problem. And just start talking and don't be afraid to really tell me. I give every patient the opportunity. I say, what would you like to try to get out of the therapy that I'm going to give to you? And to me, that's their opportunity to bring up anything and everything that they want to address. And just don't be whether it's me or someone else, don't be afraid to talk to your provider about the problems you're really experiencing. You're not the only one suffering from it. I guarantee it.
Yeah. Peptides and age management with Dr. Kris. That's the name of this show, where we try to do this weekly as often as possible. Dr. Kris is the owner of the research clinic, and these conversations are intended as educational, and you should always consult your physician before changing your medical program. And if your physician needs to reach out to Dr. Kris, guess what? He's one of those doctors that doesn't mind. He's happy to coach your doctor. And if your doctor is not getting on board and you need to make a change, reach out to Dr. Kris and let him know how he can help you. You can find out more information at the Research Clinic, www.researchclinic.com. So, Dr. Kris, what are you doing this weekend?
We're going to the lake, even though new boats in the shop, but we'll figure something out. So, yes. How about yourself?
I'm the same. We'll figure out somewhere to go get a little too much sun and smell some hot dogs cooking.
Awesome.
But as always, stay hydrated, stay sun shaded, take care of yourself, and reach out to the Research Clinic, because now is the time to start making better decisions.
Thanks, Dave.
All right. And that's a wrap.